little bit of a delay.
Okay.
So, and you can go ahead and start greeting people. And in about 15 to 20 seconds, we'll be fully live.
I'm just watching people load in. Good morning or afternoon, depending from where you're viewing us today. We want to allow a little time for people to load in. We know that we have people that are coming to view our symposium on Zoom, on Facebook, and YouTube Live. So just give us a few more seconds to allow everyone to load in, and we'll get started. Okay, let's go ahead and get started. My name is Ann Garst-Taylor. I am the Director of Community Engagement for AIM Melanoma. It is always a pleasure to work with Providence Cancer Institute. We're so happy to be co-hosting today's symposium with them. I want to be sure and thank our panelists for their collective wisdom today. And I am going to have an opportunity to tell you more about AIM melanoma at the end of today's symposium. But before that, what I want to do, because I know there will be many, many questions for our panelists, I want to explain how our Q&A session will function at the end. If you are joining us via Zoom, if you look at the bottom of your screen, you will see that there is a comment section. You're welcome to let us know where you're viewing from. But if you have a question for one of our panelists, please put that in the Q&A tab. If you are joining us via YouTube or Facebook, you can put your question into the comment section and we will transfer it over to the Q&A session. And so with that, I'm going to thank Chris Fountain for serving as our moderator today, and I'm passing the virtual podium to him. Thank you, Chris.
Hi, good morning or afternoon, wherever you're zooming in from. Excited for all of y'all to be here, and it sounds like there's a big group, and to talk a little bit about history of melanoma and then what the future looks like. We're gonna play around with technology here and see if I can actually do this right this time. Start some slides here. All right. All right. Here we go. As Anne introduced, this is we are from the Providence Cancer Institute. You can see us here wedged in between the I-84 and the Laurelhurst neighborhood, a building that started in the 50s and has since grown. And let's see if I can advance my slides. Okay. The topic today is living with melanoma, and here's another peek at the front of our cancer center with the nice covered entry for a rainy Pacific Northwest. Like I said, my name is Chris Fountain. I'm a clinical research coordinator with Providence Cancer Institute. I've had the privilege of working in oncology for the last 21 years, more recently in clinical research. Fun thing to share, outside of oncology, this is one of the places I love to be. Had the opportunity to do some backpacking this year on Catalina Island. We did this amazingly for an anniversary, 45 miles, and what an adventure. The other adventure that we've been on for a while is trying to treat melanoma. If we go way back to the 1970s, we see that we had very few options to treat melanoma. And then we had this big gap until 2011, where we had our first immunotherapy approved ipilimumab, and that was approved in the metastatic setting after progression on other treatments. We quickly moved and started seeing approvals on more targeted therapies. Now we're seeing combination immunotherapies in the first line setting. We saw improvement in our targeted therapies with better, cleaner oral drugs. And then more recently, we've seen TIL therapies, first tumor infiltrating lymphocytes approved in the melanoma space, and treatments approved for uveal melanoma. To go back a little bit in the history, we also did studies like this, which Dr. Curdy will recognize. Lots of drugs that we no longer use in melanoma with outcomes like toxicity is unacceptable. Since then, we've moved further and are looking in what we call the adjuvant or neoadjuvant setting, so prior to surgery or right after surgery, looking at where these immunotherapies fit in to avoid metastatic disease in our melanoma patients. This is really exciting work, and both of these studies have published and given our providers more direction in how to treat folks with early stage melanoma. With no further ado, I'd love to introduce Dr. Brendan Curdy, our first presenter. Dr. Curdy started his career in tumor and T-cell immunology back east at the NCI's Biological Response Modifier Program in 1990, back when I was still in high school. He joined the Early Childhood Research Institute at Providence Cancer in 2002. He is the Robert W. Franz Endowed Chair for Clinical Research and Director of the Melanoma Program at our institute. He works every day with researchers to translate basic or bench science into clinical trials and improve care for patients with melanoma and other advanced malignancies. He treated his first patient with adoptive cellular therapy back in 1990. Since then, he has authored and managed dozens of first-in-human clinical trials encompassing cellular therapy, cytokine therapy, immune co-stimulators, and cancer-attacking viruses. His talk today is on tumor-infiltrating lymphocyte therapy in melanoma. Dr. Curdy.
Thank you, Chris. And hopefully you can all see my screen. Again, thank you for the introduction. Getting over a little bit of a cold. I promise no one can catch my cold from participating in this seminar here today. And as you've heard, I'm going to talk about ACT, or adoptive cellular therapy. As is true with a lot of technology, there's a lot of jargon. I will do my best to define what those terms are as we proceed with our discussion here today. And I also take every opportunity I can to include puns in titles for my talks. And so TIL, or tumor infiltrating lymphocyte therapy, the future, ? And we'll see as we have our discussion here today. So these are my disclosures, not relevant to the topics today. And so here are some questions that I'll pose and do my best to answer this afternoon. And so really, what is adoptive therapy? We bandy this term about, but what really does it mean? What are the main components of this type of treatment? What sort of immune cells are best to kill cancer cells? And I'll hint at the final answer, which is we don't really know, although we have some ideas as to what the best candidates are. My follow-up question is, how do these cells actually kill cancer? That's another question to which we don't have a full answer, but I'll just say most of us think that it's CD8 T cells, and I'll talk more about those later. But I'll say there's room for other cells and other immune therapies as well. So, putting all of this together, of course, we'll talk about some early efforts and how our current procedures and clinical treatments have come together and what all of the moving parts are. I'll talk about some recent results that led to the FDA approval of lifileucel for certain patients with advanced melanoma. And I'll specifically talk about the individuals who for whom this therapy could be offered. So this idea of adoptive therapy goes back well into the mid-century part of the last century. And so this term was first used in the mid-1950s. And this comes from mouse medicine and an observation that if you took immune cells from lymph nodes in mice that had rejected a tumor and took those immune cells and put them into another mouse, the mouse that received the cells could reject the same tumor but not a different tumor. And so in some sense, the new mouse had adopted the cells from the mouse that already had immunity. And although there was a knowledge of immune cells and T cells and B cells, that knowledge, as you might imagine, was not all that sophisticated in the mid-1950s, but it was a robust concept that has lived to the present day. And so again, immunity in a transplant model could be transferred from a donor mouse and adopted by the recipient mouse. And so when did the first human get adoptive cellular therapy? Well, if you count allotransplant, so basically bone marrow transplant, and receiving bone marrow cells from an individual who has the same tissue type, then the answer is 1957. So again, a technology that goes back over 65 years. The first solid tumor adoptive cell therapy clinical trials were done in the 1980s, starting with so-called LAC cells. LAC stands for lymphocyte-activated killer cells. The first TIL patient, or tumor-infiltrating lymphocyte patient, was treated in the 1980s and is still alive, by the way. The FDA granted accelerated approval in 2024 for this technology. So after 40 years of work, this has finally come to fruition. And we'll talk a lot more about that coming up. So there are a great many moving parts to this therapy, and it starts out with a surgeon removing a melanoma deposit from the patient's body. The melanoma that's removed by the surgeon has to be of a certain size because you have to get a certain number of immune cells at the end of the processing. After the tumor is removed from the patient's body, it's taken to a lab, and the tumor is actually chopped up into little fragments, and it's grown in certain conditions with certain immune substances, such that the immune cells grow, but the melanoma cells die. And after that is done, you usually get a number of immune cells, T cells specifically, that are in the billions. So you start out with a few thousand or perhaps 100,000, and then you get billions after the processing. The patient also has to be prepared to receive their own cells back, and this involves lymphodepletion or chemotherapy, basically to lower blood counts. The chemotherapy medicines, we'll talk more about this later, but the specific ones are cyclophosphamide and fludarabine. After that, the patient gets their own immune cells transferred back or adoptively transferred. They then get interleukin-2, which is the strongest known growth factor for T cells. And this helps their recently adopted cells to make copies of themselves to proliferate and also to make them cytotoxic. In other words, have better ability to kill the melanoma cells that may be remaining in the patient's body. There are a lot of side effects, though, that need management. Some of them relate to the chemotherapy itself. Some of it relates to the tumor breaking down. That can be a good thing, but also a complex thing medically. There can be a number of immune events that also come into play, and those need to be understood and managed. This is a cartoon that depicts all of the words that I just uttered. And so for those who are more visually oriented, but you can see in the top left, a melanoma tumor deposit can be removed. It can be on the skin, but it could be in a lymph node or lung or liver. There are other complexities, as you might imagine, from doing more invading or invasive surgery to do a tumor harvest. The tumor specimen taken to the lab, chopped up, grown in this case with interleukin-2 and something called OKT3 or anti-CD3. I won't go into that minutia, but just to say there are different substances that the T cells need to become active and to proliferate in the lab. The patient gets their cells back. This slide also depicts some extra steps, which are more experimental. And so I won't go into that, but just to say that there's a lot of effort to pick the winner or the cells that are very most likely to have the abilities to kill the melanoma cell. The patient gets their cells back, and as I mentioned before, they also get some interleukin-2 after the transfer of the cells. So I mentioned a couple of times this idea of conditioning regimen or lymphodepleting chemotherapy. So what the heck is that, and why do we do it? Because the chemotherapy itself really does not confer any melanoma fighting benefit, at least not best we know, but it can kind of reboot or reset the immune system. And so there are a number of different mechanisms to that. You can reduce inhibiting, also known as regulatory or Treg T cells. Pardon me. Chemotherapy will increase physical space in the bone marrow. As the bone marrow recovers from the chemotherapy, it makes a number of substances that are basically like vitamins for the T cells. They can promote the growth and the persistence of those T cells in the body. And again, the chemotherapy really doesn't kill melanoma. That's not part of the rationale. There's a lot of, I'll say, tradition to these regimens, and some early observations, actually some made back in the 70s and early 80s, show that low doses of cyclophosphamide, a medicine that's been used since the 1950s to treat cancer, but low doses of that medicine can, again, have this effect on regulatory T cells. The dose that we use now most often in lifileucel, well, most often in clinical trials, but also the standard with lifileucel adoptive cell therapy was actually used in the 1980s and is unchanged. And this was the same regimen that I learned as an oncology fellow in the late 80s and going into 1990 when I started my career at the NCI. So that part has been held constant throughout the history of this treatment. Pardon my cough. Let me talk a little bit more about those early results from the 1980s, in this case published in 1988. I remember presenting this article as an oncology fellow because of how eye-opening it was in that era. And you have to understand this in the era where there were really no proven therapies for patients with melanoma. So in this study, there were 20 patients. They had, as is typical for melanoma patients, disease in basically all organs of the body. As you can see, they had chemotherapy, immunotherapy. Even in this era, they got, I'll say billions of cells, and understanding the lab processing was just being figured out kind of on the fly, but it was a pretty good first efforts, because these are still the same sort of cell numbers that we get today from the cell processing. The composition of the cells has changed, more CD8s compared to CD4s. I realize this is a lot of insider baseball, but just to say, in immunology circles, CD8 T cells seem to confer the strongest anti-tumor effects, but we shouldn't forget about some of the other immune cells either. And so this is a depiction of response. And I also offer this a little bit for the quaintness. This is a quaintness of this tumor response. Nowadays, of course, there are PET scans and circulating tumor DNA and all manner of other sophisticated means of assessing patient response. But here's a chest X-ray showing large melanoma deposits in the lungs that disappeared in this patient, and as you note, in under 6 weeks. And so, again, this was a very amazing finding given that era and the absence of other treatments that could do this. So overall, about half the patients responded. They responded in different organ sites. The duration of response was not that long, depending on your point of view, but the best responder, as I mentioned before, still alive and well, 36 plus years after the treatment. So these are the final words from that paper. I won't read them all to you, but other than to say it was a lot of work, and the authors concluded that this work should continue. And my response to that is indeed. And it only took, again, 40 years to make this a workable therapy. I'll pivot now to modern times. And so this is work from the last, I'll say, 7 or 8 years. And these are the two studies that led to the approval by the FDA for adoptive cell therapy in melanoma. The two studies are actually the same study. And so in the upper left are the initial patients, and the lower right is the publication of all of the patients, including those that were described in the initial study, but those who were added on during the conduct of the study. I show this in part to show how clinical trials evolve in a way, and again, that'll be a little bit more clear as we head forward. And so these were all patients who had advanced melanoma and who had received modern therapy, so using medicines like nivolumab or pembrolizumab or ipilimumab, and also the various oral targeted therapies if their melanoma had a so-called BRAF mutation. There were 189 patients enrolled. 153 of those individuals received T-cell therapy. Some, however, even though they signed up, did not get the cells. Some of that was due, unfortunately, to the very rapid growth of the melanoma. Some were due to TIL production failures. So despite meticulous lab technique, it was not possible to grow the immune cells outside of the body. I'm casting no shade whatsoever at those who were doing this work. It is very difficult work to carry out. And 3 individuals opted for other treatment options. Again, they received the traditional lymphodepletion with cyclophosphamide and fludarabine. They also got a medicine known as Mesna or Mesna, depending on where you learned your oncology. But the Mesna is something that protects the bladder from the toxic effects of the cyclophosphamide. And so, unfortunately, the cyclophosphamide at high doses can cause injury to the bladder, and this medicine helps to prevent that. After the cells were infused, the patients got interleukin-2 or IL-2. IL-2 is an immune substance that all of us make, all of us have in our bodies, but when we give it as a medication, it's given in amounts many, many thousands of times greater than the body can make on its own. And in so doing, again, it can help these T cells to live long and prosper in the body. The way that the IL-2 is dosed is a little bit different than traditional interleukin-2. And so a few of you on the call may know me as the IL-2 guy. And so that's not my, I'm not here to go into that long and complex history, but just to say that the IL-2 with cell therapy is a little bit kinder and gentler in large measure because fewer doses are given. And it's also safer to give, especially in places that aren't highly familiar with this complex form of therapy. So I'm going to just show you some of the results, and this is a so-called waterfall plot. So any bar that is heading down is actually good. So that is indicative of a shrinkage of tumors. Bars that head up imply a growth of the tumors and their measurements. And so this is the early effort, and this next slide is the entire patient population. And just toggling back and forth, you can say these graphs have about the same shape. And so what I would conclude from that is that the results held up as the study got bigger. That's not always the case, but that was the case here, and that's a good thing. Of course, in the study, they also looked at survival. And so this is the early part of the study. And unfortunately, as these curves go down, that indicates, unfortunately, that patients have succumbed to their melanoma. But in light of the fact that all of these patients had progression of the disease after our current state-of-the-art immunotherapy, seeing patients survive 6 months, 12 months, even longer in some individuals is a good thing. And again, this is the survival from the larger study. It's a little bit different compared to the initial one. And so again, that just points out the nature of clinical research. The more patients you treat, you get a stronger, a more robust signal. But again, the overall shapes of the curve are the same, and clearly patients are surviving. Not everybody, but a significant number are surviving longer as a consequence of receiving the cellular therapy. So this is just showing the same thing in a table. Roughly a third of patients had an objective response, and those are fancy words for saying what percent of patients show scans that have a certain amount of improvement, and there are a set of rules that we use to measure and compare scans to determine these measurements. This is a table listing the side effects, and most of the side effects are in relation to the chemotherapy. So there are certainly some from the interleukin-2, but essentially none or very few that relate to the cells themselves. And you might expect that because these were cells that were in the patient's body before the processing. Again, they're in large numbers, and so maybe that might cause some differences, but by and large, the side effects of this treatment come from the conditioning regimen chemotherapy and also the interleukin-2. The package insert, so that's the FDA description of the trial, includes some stern warnings that some patients can die as a consequence of the chemotherapy. That is true, but again, in centers that have experience giving this form of therapy, it can be offered relatively safely, but there's no free lunch in this or any other aspect of oncology. So who should get lifileucel adoptive cell therapy or TIL therapy? Patients with unresectable or metastatic melanoma who've had growth of their melanoma despite an immunotherapy containing a PD-1 medication, and or targeted therapy for those patients whose melanoma has a BRAF mutation. There are other qualifications or requirements. So you have to have a certain amount of melanoma that the surgeon can remove to process the immune cells. You have to have relatively good functional status, so-called ECOG status or Eastern Cooperative Oncology Group status. And so sometimes I refer to this in the clinic as the eyeball test, or basically how robust patients appear when they come into the clinic. This is not a treatment for patients with active infections. And also, patients have to have relatively normal cardiovascular status to tolerate the interleukin-2 part of the therapy. So, as Chris mentioned, most of my career has been dedicated to clinical trials work. And so with almost every single talk I give, I make some mention of new ideas that we and others are working on. And so in the surgical specimen for tumor harvest, there are quite a few different varieties of immune cells there. And so Dr. Andy Weinberg, who works in our institute, his lab determined that a particular subset that may only comprise a few hundred or 1,000 or two cells in a tumor specimen have the very greatest abilities to fight the cancer. And this is true not just in melanoma, but in other tumors. But we think that there are ways, again, to select TIL that might have greater anti-tumor abilities. You can add genes into cells now, which is awfully cool, but you can give them new properties that they didn't previously have. And this has been used in a variety of tumors. Dr. Ram Leidner and Dr. Eric Tran in our group have been working on this in pancreatic cancer as well as other cancers, but this technology could also be employed in melanoma. And there are also ways to alter T cells to make them hardier when they encounter the tumor in microenvironment, which is a very hostile place, which has very little normal nutrient balance. It can be very acidic. It can have low oxygen. And so those things are advantageous to the tumor, but not so much to the immune cells. And so their technology is being worked on to make the immune cells, again, able to function and to get rid of cancer. So here are some conclusions that I would offer: that TIL therapy works after a lot of work that spans over 4 decades. Lifileucel TIL is the only FDA-approved therapy for selected patients with advanced melanoma after they've had progression on checkpoint immunotherapy or BRAF-targeted therapy. And there's still plenty of work ahead and room for improvement with this technology. Thank you.
Thanks, Dr. Curdy, for a really great update on where we are with TIL therapy. If you have questions regarding this presentation, please add them to the Q&A and we will address those at the end of the talk. Our next presenter is Dr. Matthew Taylor, and I will introduce him as a true left coaster. Let me see if I can get my slides to show here. Apologies. PowerPoint will always be beyond me. Dr. Taylor attended medical school at Oregon Health and Sciences here in Portland, and then headed up the I-5 corridor to do his internal medical residency at University of Washington. The great weather in Portland brought him back to do his fellowship at OHSU. And now he is here working with our melanoma program at the Providence Cancer Institute. Dr. Taylor, take it away.
Thank you, Chris. Let's see if I can get my slides to show properly. Okay, thank you, Chris, for the kind introduction, and thank you to the organizers for inviting me to speak with you today. So I'm going to be talking today about some adjuvant and neoadjuvant therapies, and I'll explain what these are. And for the most part, we're talking about melanoma that has been diagnosed in somewhat of an earlier stage when it's confined either just to the skin or has spread to regional lymph nodes, and we'll talk about what this means. So let's see if I can get this to advance. There we go. These are my disclosures. So first of all, let's just start with some terms. So we're going to talk about adjuvant and neoadjuvant. So adjuvant therapy is the term that we use to describe treatment that is given after surgery to remove the cancer. Neoadjuvant treatment is the term we use to describe giving some kind of medication or treatment, could even be radiation therapy, but some type of treatment that is given before surgery to remove the cancer. And we'll talk about why this is an important way to treat cancer. So just to level set, I first wanted to just talk about what is the current standard of care? What are the medications that we use? What are the options that are available to us? So if someone is diagnosed with melanoma today, what do we have that's approved by the FDA that we use routinely in the clinic? So I've broken this down by different stages of melanoma. So if someone is diagnosed with stage 2B or 2C melanoma, that means it's a relatively thicker melanoma, but it's confined just to the skin where it started. It has not spread to lymph nodes in the vicinity. It has not spread into the lungs or the liver. That's a stage 2B or 2C melanoma. So patients that have undergone surgery to remove that melanoma tumor are then eligible to be treated with 1 year of immunotherapy with an anti-PD-1 drug such as pembrolizumab or nivolumab, known as Keytruda or Opdivo. If the melanoma is more advanced, if there's stage 3, meaning that the melanoma has spread from where it started in the skin to one of the regional lymph nodes, these patients, after undergoing surgery to remove the tumor, as well as a sentinel lymph node, or even if the lymph node is obviously involved with cancer on a PET CT or a CT scan, after surgery to remove that melanoma, these patients are also potential candidates to receive immunotherapy with a drug like pembrolizumab or nivolumab. Similarly, for stage 3 melanoma patients who have a mutation in a gene called BRAF, about 50% of melanoma patients will have a mutation in this gene. Those patients could be treated with what we consider targeted therapy. These are pills that target this mutated gene within the melanoma. So that's another option for patients, in addition to what they could either receive immunotherapy or the targeted therapy for the BRAF gene mutation. And lastly, on the right, patients with stage 4 melanoma, meaning the melanoma has spread from where it started and traveled to the lungs or the liver. After undergoing surgery to remove melanoma tumors, these patients can also be treated with adjuvant immunotherapy with nivolumab. So those are the current standards. That's what we use in the clinic every day to treat patients who are diagnosed with melanoma at these various stages. And what I'm going to share with you today is some exciting research that's been evolving over the past several years that really is going to change how we treat patients in the future with melanoma. So just to kind of review some of the clinical trial data, and we'll try to not get bogged down into the weeds, but just to provide a bit of a background for why do we use these therapies and why are they helpful. So this is from the Keynote 54 clinical trial. So this was for patients with stage 3 melanoma, and these patients were put into 2 groups to either receive pembrolizumab or a placebo infusion. And what this clinical trial showed was that patients who were treated with pembrolizumab, depicted in the blue line, these patients did much better than patients who received a placebo. There was a greater percentage of patients who were cured from the melanoma. There was a less risk of recurrence of melanoma in the patients treated with pembrolizumab. So this was one of the early trials that really demonstrated that patients with stage 3 melanoma, after having undergone surgery to remove the melanoma, should be treated with adjuvant immunotherapy. And this is a clinical trial that looked at treating a similar population of patients. So patients with stage 3 melanoma who had undergone surgery to remove the melanoma. To qualify for this trial, these patients had to have a known mutation in the BRAF gene within their melanoma. So these patients could be treated with these pills called dabrafenib and trametinib, or Taflinar and Mekinist. And so they were treated with these pills for a year. And the clinical trial data here is also very impressive and very similar. If we look at the curves, that at 5 years, patients treated with these pills did better than patients treated with a placebo. And so again, this was very strong evidence that treating patients with pills targeting this BRAF gene mutation, this can be very successful, very effective in reducing the chances of the melanoma coming back again after surgery. So this led to the approval of these drugs for patients with stage 3 melanoma with the BRAF gene mutation. So based on the success of treating patients with stage 3 melanoma, we then did clinical trials with patients at an earlier stage, looking at patients with stage 2B or 2C melanoma to see if offering these patients immunotherapy after surgery is beneficial. Does this help reduce their risk of recurrence of melanoma? And in fact, the answer was yes, it does. So in this figure, we're again showing patients either treated with pembrolizumab in the green line versus a placebo in the purple line. And what this figure is demonstrating is that patients treated with pembrolizumab after surgery to remove stage 2B or 2C melanoma, these patients have a decreased risk of recurrence of the melanoma. So this also led to the approval of these immunotherapy drugs for patients with stage 2B or 2C melanoma. So now I want to tell you about a clinical trial that we've been a part of for a number of years that's been very exciting, and we fully expect this is going to change the way we treat melanoma in the future. And I'll just start with a little bit of the background of this. We started working with a company that was known to very few people at the time by the name of Moderna. So this was back in, I believe, 2017, maybe 2018. And this company, Moderna, was making mRNA vaccines to treat cancer. And it wasn't until the COVID-19 pandemic that this company, Moderna, decided they would make vaccines for the COVID-19 virus, that now Moderna is a household name. But the same company they had their roots in making vaccines to treat patients with cancer. So the way this vaccine works is really quite interesting, and what this is. So what happens is patients would have a biopsy of their melanoma that would diagnose their melanoma, and then this melanoma biopsy specimen gets sent to Moderna. Moderna then processes the tumor and tests for different, to find out which genes are mutated within their cancer. And based on the genes that are mutated, they then generate an mRNA vaccine that is unique and specific to that individual only. So each vaccine that is made is basically a custom vaccine for the individual with that cancer. So this is not a vaccine that they can make a ton of them and put them on the shelves and just take them off the shelf and give them to anyone. Each vaccine is custom made for the individual, that is based on the mutations within their cancer. So in this clinical trial, patients with stage 3 melanoma or stage 4 were randomized to either get the current standard of care, which is pembrolizumab. So undergo surgery and then get adjuvant treatment with pembrolizumab for a year. That was the standard that it was being compared with. Or patients would receive pembrolizumab in combination with a vaccine that has been this mRNA vaccine that is a custom fit for their particular cancer. And this is the Kaplan-Meier plot. This is the way, as you've been able to see, this is the way we like to present a lot of data showing the recurrence-free survival. So what percentage of patients are still alive and well and have not had a recurrence of their melanoma? And what you'll see is patients treated with pembrolizumab in combination with this vaccine called mRNA 4157 did much better than patients who were treated just with surgery followed by pembrolizumab by itself, which is still, as of today, one of the current standards. So this was very exciting to see that the addition of this personalized tumor vaccine can really improve the benefits of immunotherapy and reduce the risk of recurrence of melanoma. So this has not yet been approved by the FDA, The clinical trial is ongoing, but we are all anxiously awaiting the approval of this therapy because this really seems to improve upon the current standard of care. So let's pivot now and talk a little bit more about neoadjuvant therapy. So again, the reminder, neoadjuvant means we're giving some kind of therapy before doing the surgery to remove the bulk of the tumor and remove all of the melanoma that's present. And so why would we do this? Why would we give a therapy before we do surgery to remove the cancer? So it's interesting to point out that the majority of what we call tumor reactive T cells, these are the immune cells that can recognize and fight and attack the melanoma. The majority of these T cells are found within the tumors, as well as within the draining lymph nodes that are near the tumor or within a lymph node metastasis. And so the cells that we want to activate to be able to fight melanoma are actually already in the tumor. So if we undergo a surgery and remove the tumor and remove the lymph nodes, yes, we're getting the melanoma out, but in effect, we're also removing a significant percentage of the T cells that can actually see and would have the ability to fight and attack the melanoma. So with this concept in mind, if we can treat patients with immunotherapy before they undergo surgery, we have an opportunity to activate those very important T cells that are recognizing the tumor before the tumor is surgically removed. So this gives us the best chance to activate the immune system to fight the cancer at an early time point. So I'll share with you this clinical trial. This is called the SWOG S1801. This was a clinical trial in which patients with stage 3 all the way to stage 4 melanoma who were candidates to have surgery to remove all signs, all evidence of melanoma. These patients were randomized to either undergo surgery and then get 1 year of adjuvant pembrolizumab, again, as the standard of care, or to receive 3 cycles of treatment with pembrolizumab before surgery, and then to continue to get 15 more cycles of treatment. So it's basically giving the immunotherapy a little bit before surgery and then 15 cycles after surgery. And what you can see from the figure here on the right, patients who were treated with pembrolizumab before and after surgery did better than those who immediately underwent surgery and were then treated with pembrolizumab. So this was very exciting to again see that we can improve upon the current standard, we can do better, and we can help reduce the risk of melanoma coming back in these patients with locally advanced melanoma. This is another clinical trial called the NADINA study, and this was, again, looking at the same concept. If we give immunotherapy before surgery, can we improve outcomes? So in this clinical trial, different medications were used, and so the control arm is depicted with kind of the orange bar there, where patients with stage 3 melanoma would undergo surgery to remove all signs of melanoma. And then they were treated with 1 year of nivolumab, excuse me, 1 year of nivolumab immunotherapy. That's one of the current standards of care that we use for this disease. And then in the investigational arm of the study, patients were treated with 2 cycles of ipilimumab and nivolumab, also known as Yervoy and Opdivo. This is a regimen of immunotherapy that we use frequently for patients with advanced metastatic stage 4 melanoma. So these patients were given 2 cycles of this treatment, then they underwent surgery. After surgery, they would look to see what was the result, what was the outcome. And so if all of the tumor or a significant amount of the melanoma had been destroyed by the immunotherapy, that was it. That was the end of their immunotherapy. They did not need to receive any more immunotherapy after surgery. If they had more of a partial response or they did not respond to the immunotherapy at the time of surgery, then those patients were treated with additional adjuvant immunotherapy, or if they had a BRAF gene mutation, they were treated with dabrafenib and trametinib, BRAF and MEK inhibitors for 1 year. And the purpose of the clinical trial was to see, can this improve on what's called event-free survival? Can this prevent recurrence of melanoma? Can it improve overall survival? And so those were the objectives of the study. So what I'll highlight here is that in the patients who were treated in the neoadjuvant group, meaning they got ipilimumab and nivolumab for 2 cycles, and then they underwent surgery, when the pathologists looked at the specimens under the microscope, they found that 55 to 60% of these patients had undergone a very significant immunologic response in which either all of the melanoma had been completely destroyed or a very significant percentage of the melanoma had been destroyed. So this was a really impressive high success rate for the immunotherapy destroying the melanoma. A smaller percentage of patients, maybe 8 or 9%, had a partial response. And unfortunately, about a quarter of patients had no response. The immunotherapy was not able to activate the immune system to attack the melanoma. So here again is our Kaplan-Meier plot, and this is showing in the blue line the patients treated with the neoadjuvant ipilimumab, nivolumab prior to surgery, compared with those who, in the red line, underwent surgery immediately and then were treated with a year of immunotherapy. And so again, this trial demonstrated that immunotherapy given before surgery was very beneficial in reducing the risk of recurrence of melanoma for these patients. So very exciting to see such a significant improvement over our current standard of care. This just demonstrates that this benefit was observed both in patients with BRAF gene mutations as well as melanomas that don't have a mutation in the BRAF gene. This is kind of a busy, clunky slide to look at, but the message of this slide is, and this will come as no surprise, the patients who had an excellent immunologic response, meaning they got immunotherapy before surgery, and at the time of surgery, the pathologist found that almost all of the melanoma had been destroyed. These are patients who had an excellent remission from melanoma. And patients who had a partial response to the immunotherapy, their response to the therapy overall was kind of intermediate. And unfortunately, patients who did not respond to the immunotherapy and the melanoma had continued to grow at the time of surgery, sadly, these patients did not do as well, and we need to find better ways to offer effective treatments for these patients. And just to touch on side effects very briefly, the takeaway message is that treatment with ipilimumab and nivolumab given prior to surgery causes more side effects than doing surgery and then giving nivolumab by itself. This comes as no surprise to us. We've known for many years that the combination of ipilimumab and nivolumab causes more side effects than an anti-PD-1 drug by itself, such as nivolumab or pembrolizumab. So this is an irritating slide that I made to try to put several of these clinical trials into one table. And so let's just look at the column titled EFS. This is event-free survival at 2 years. And so if we come down from the top, the SWOG 1801 study showed that treatment with neoadjuvant immunotherapy was better than doing surgery first and then immunotherapy. If we look at the NADINA study, immunotherapy prior to surgery was better than doing surgery and then giving adjuvant immunotherapy. And then the next line, the mRNA 4157 and pembrolizumab, that study was purely an adjuvant study. It was only after they'd had surgery to remove the cancer. And so we don't have the same neoadjuvant to adjuvant comparison, but we have a very impressive 77% of patients having no sign of recurrence of melanoma at 2 years. And then there's another clinical trial that I didn't mention previously, which is a combination of 2 drugs, one called relatlimab, the other nivolumab. This combination is known as Opdualag. And so patients treated with this Opdualag therapy prior to surgery to remove the melanoma, these patients had an 80% event-free response. So the message is we've seen lots of different approaches to improve upon what the current standards of care are for treating melanoma. And we're excited to see these things get approved and enter general use in the clinic. I want to show just a brief case report of one of my patients. So this is a 64-year-old gentleman, Southern Oregon. So he had a pigmented lesion, a dark spot on his back, had a biopsy done, and this was demonstrated to be melanoma. And so he had surgery at the time to remove, well, no, he did not have a wide local excision or sentinel lymph node biopsy, just an initial biopsy at the time. So that was not the standard of care. That was poorly done. Unfortunately, 2 years later, he shows up to see his doctors in Southern Oregon and is found to have a large mass in his armpit. So he has a PET scan, which showed this bright yellow mass in the left side of your screen. That's his right armpit. And so a biopsy was done, and that was shown to be melanoma. So he basically had melanoma that had recurred 2 years after his initial biopsy. And so at this point, he got referred to come talk to me about what we should do about this. So based on the NADINA study and the results showing the benefits of doing neoadjuvant immunotherapy, I recommended that we treat him with 2 cycles of ipilimumab and nivolumab. And so he got that treatment. And then he went and had surgery to remove the lymph nodes from his armpit. And at the time of surgery, when they sent this to the pathologist said that all the melanoma was dead. There was no viable residual melanoma at all. So he's a patient who had a complete pathologic response to just 2 cycles of immunotherapy. Unfortunately, he developed some bad side effects from the treatment, in which his immune system attacked his intestines and caused some severe diarrhea, and he was treated with prednisone, and the side effects resolved. So I just highlight this to show that this happens not just in the clinical trials, but this is something that is happening and helping our patients today. So to conclude, neoadjuvant immunotherapy, again, immunotherapy given prior to surgery, has a very high rate of pathologic responses, meaning this can really help the immune system become activated and fight and destroy melanoma prior to surgery. Neoadjuvant immunotherapy in what I'll call macroscopic stage 3, meaning that you can either feel that there's a lymph node or you can see that there's a lymph node that's enlarged on a PET scan or a CT scan. That's what we would consider macroscopic stage 3. For those patients, neoadjuvant immunotherapy is better than our current standard of doing surgery first, followed by adjuvant immunotherapy. And fortunately, we didn't see any surprises with side effects from neoadjuvant immunotherapy compared with adjuvant immunotherapy. A couple of unanswered questions. We now have an embarrassment of riches of data from several different clinical trials with different medications, all showing improvements in our current standard of care. So what is the best form of neoadjuvant immunotherapy? Is it pembrolizumab by itself? Is it the combination of ipilimumab plus nivolumab? Is it the combination of relatlimab and nivolumab, that one called Opdualag? Or is it this triplet regimen of pembrolizumab plus the BRAF and MEK inhibitors? And we don't know yet which of these is the best. They've all shown positive results. We also don't know where is this Moderna vaccine going to fit in with this. We know that this Moderna mRNA 4157 vaccine in combination with pembrolizumab is very effective and is better than doing pembrolizumab by itself. So this begs the question, will we just give this after surgery? Will there be a situation in which we might give some immunotherapy prior to surgery and then after surgery treat with immunotherapy plus the personalized tumor vaccine? So we still have a lot of work to do to sort out these questions and understand what is the best way to treat earlier stages of melanoma. But it's very exciting to see how quickly progress is being made and how new therapies are impacting the lives of our patients. And with that, I will conclude my remarks.
Thank you, Dr. Taylor. I'm looking forward to the clinical trial that answers all those unanswered questions. Great presentation. Definitely addresses and shows how we're moving forward at a pretty quick pace in treating melanoma. I'd like to introduce our last speaker of the day, Noah Curtis. And we're going to do the fun thing where I try and share my screen again. We'll see how this goes. All right.
Grade E24. So grade EV24. So grade for the touch.
There we go. Maybe. Apologies again. I'd love to introduce Noah Curtis. Noah is an outpatient oncology social worker at the Providence Cancer Center in Portland and holds an advanced certification in palliative care. Noah works with patients and their care partners from diagnosis through survivorship or until end of life. Noah provides individual and group support focused on holistic support of the individual. Noah's clinical focus is self-advocacy, meaning making, and self-compassion. Outside of work, Noah enjoys exploring the Pacific Northwest, rivers, forests with friends and family. Noah, take it away.
Thank you so much. So I'll be talking today a little bit about survivorship and how folks make meaning during their cancer experience. So survivorship can mean many things. It's different for each person, and how each person thinks about their experience is unique. I'm hoping that this presentation can bring some awareness to how you're thinking about your cancer experience and maybe bring a little curiosity about how others might be thinking about their experience as well. So survivorship can mean many things. One way to look or think about survivorship is that it starts at diagnosis. The moment a person is diagnosed, they are a cancer survivor. Other folks might use this term if they have chronic cancer, or others might use this word at specific times during their cancer experience, say at the end of treatment, or if there's no evidence of disease. And some may never identify with this term. And if that is you, that is okay too. I'm hoping that you feel welcome in this presentation today, and that there's something here for you as well. So starting with a common place where we think of survivorship often is the end of treatment. Often folks think of treatment as maybe a marathon or a roller coaster, something with a very definite ending. And what you and others expect is a big yay. And what actually happens is all of the feelings. The end of treatment is often when people feel really big feelings. A tidal wave of emotions can come when you're through with the immediate stress of diagnosis and the hard work of treatment. And coming back to the daily routines of life and realizing that you and your relationships have been changed by this experience. People are often surprised that along with the yay or the relief of being done with treatment, that they find they're missing the encouragement of the team. There's a sense of now what? There's a loss of routine. You spent a lot of time getting used to the rhythm of treatment and appointments, and now that's changing again. Maybe missing the feeling of doing something about the cancer, or worried that the cancer is coming back. And this is all a normal part of the human experience. Anytime there is change, even positive change, we might experience loss. And grief is our natural response to loss. So then the work becomes, how do we honor both grief and gratitude? Often folks tend to feel like they can spend time only in one of these bubbles. So how do we allow ourselves to have gratitude for what's going well, and also give space to recognize how things have changed, and honor that loss and grief that might come with it. This might begin by attempting to give yourself permission to name your feelings as they arise, recognize how life has changed, learning about your new normal, and reconnecting with yourself and your body. You might still be dealing with very real physical symptoms, or feeling more distant from your sexual self, or be anticipating life changes to prevent a cancer reoccurrence. You might start and continue to connect with others, staying connected to your medical team, remembering that they are still available to you to ask questions and to navigate symptoms going forward. And finding ways to process your experience. This could be talking with a social worker or a counselor, maybe joining a support group, journaling, making art, prayer, talking to friends and loved ones. It looks really different for each person. One of the ways of processing your experience could be just taking a look about how you're making meaning of your situation. So I wanted to share this study out of Lancaster University called the Metaphor Menu for People Living with Cancer, where they interviewed cancer patients about how they make sense of their experience and looked at what language they use. And what I love about this menu is it shows that there's no right way to think about one's cancer diagnosis, but it also highlights that there are so many different ways to think about one's experience. It also brings to light how we might have conscious or unconscious ways of thinking about our experience. So my invitation to you as we go through a few of the examples from the menu is to try on each metaphor and just see how it fits. You might notice that you have really strong opinions about some of them, and all of that is welcome. We're just trying it on. And just a reminder that all of this is language from others who have a cancer diagnosis. So our first one, imagine it a bit like a scary fairground ride. It might be scary in places, but it will eventually stop and you can get off. Be strong, be brave, and we will be here to hold your hand if you need it. My journey with cancer may not be smooth, but it certainly makes me look up and notice the scenery. Some journeys with cancer will be longer and others short, but what matters most is how we walk that journey. I don't intend to give up. I don't intend to give in. No, I want to fight. I don't want it to beat me. I want to beat it. Having cancer is not a fight, but a relationship where I'm forced to live with my disease day in, day out. Some days cancer has the upper hand, other days I do. My way of dealing with my diagnosis is to bend with the wind. I compare life after cancer to walking with a stone in your shoe. If you let the stone rest right under the sole of your foot, it hurts every time you take a step, and it's hard to move forward. But if you can maneuver the stone to sit between your toes, it is still there, but you can walk the fine line of life without hurting. So you might already start to notice which metaphors from the menu seem familiar or not as familiar, and which ones you like best. And you also might start thinking about how each of these might impact how you feel about your cancer experience. So the roller coaster recognizes the ups and downs of cancer, talks about it being somewhat temporary in nature, and might contribute to that expectation that things are going back to normal after the ride. The journey, one of the main metaphors that we use to talk about cancer, highlights the perseverance, multiple different struggles, no clear endpoint. Some find this too gentle, not recognizing the immediacy of effort that a cancer diagnosis requires. The fight, another very common metaphor, the battle or fight with cancer. Some people find this very motivating. It helps them find strength to do hard things. Others find that this suggests that either they win or the cancer does. And some find that what they're fighting for starts to change over time. Bend with the wind might feel passive or maybe even elusive to some, while others feel it depicts the flexibility to match the uncertainty that is inherent in a cancer diagnosis. And rock in the shoe shows the discomfort and constant impact of cancer. Might not be as useful at the beginning of a diagnosis. It might feel more relevant to someone after treatment or living with chronic cancer. So again, no option is right or wrong. They all have their uses to different people, all have strengths and weaknesses, and some might feel more relevant at different times. But all of these are an example of reframing. And when metaphors are working the best for us, they help us acknowledge the uncontrollable, focus on what's in our control, recognize our strengths, and use those strengths. So how can I use strengths in this situation to move in the most helpful direction for me? So as you continue to reflect about your life and your cancer experience, I hope you can use this metaphor menu as a tool to process, knowing that the metaphor might change over time. How was I thinking about cancer when I was first diagnosed versus how I'm making meaning of what's going on now? And maybe even a tool to use with your friends and family. We all have our own perspectives depending on what seat we're sitting in. So lastly, I encourage you to recognize your own milestones and honor them in a way that feels right to you. It might be something obvious like the end of treatment, or it might be more subtle things along the way. One of my favorite examples a patient shared with me, she said, I started feeling like I was in survivorship when I started being irritated by the little things again. And for her, that was a huge celebration. These slides will be shared after the presentation, and we have links here to direct you to more information about oncology social work and our support groups that we offer here. If this idea of reframing was interesting to you, it's one of the many tools that we teach in a group that we're currently offering called Mind Over Matter. It's a virtual skills-based group focused on learning tools to cope with big emotions. We offer it several times a year, and it's open to people who have cancer and also their care partners. I hope there was something in this presentation that invited you to reflect on how you're making meaning. And here is the link to the menu in case you'd like to look at it more in the future.
Thank you so much, Noah. You get the blue ribbon for the most calming slide deck. Thank you to all of our presenters. We're now going to move into the Q&A portion of the talk, and I'll pass this on to Anne.
Thank you so much, Chris. I really, really appreciate that. Before we move to our Q&A, I want just a moment, if you will, to talk about AIMIT melanoma. First, of course, I want to, echo what you said about these wonderful presentations. I'm so thankful to everyone to our friends. I feel like we're friends now at Providence Cancer Institute. But I'd like just a minute to tell those that are watching today about AIMIT melanoma. So I will now share and do my very brief, here it is, my very brief PowerPoint. Let's see. Can you, oh, here we go, share. And can you see it? Let's see. I need to make sure it's from the beginning. There we go. Great. So for those of you who are viewing today and don't know AIMIT melanoma's origin story, I'd like to tell you a little bit about us. 20 years ago, Valerie Gill's daughter, Charlie, was diagnosed with melanoma at the age of 26. Unfortunately, she did not respond to treatment. And after she passed away, Val decided that she would form Aim at Melanoma, in that it would have two purposes. The first would be to fund research that would help us to find a cure for melanoma in our lifetime. And then the second was to support people who are living with melanoma and walking through a melanoma treatment journey. So that support comes largely through resources and information that is available on our website. And I just want to take you for just a minute to our website, to information from there, so that you will know how we are available, the information that's available to support you. By far, the most frequently visited pages are on Stage and its relevant treatment, treatment information. In addition, we have many viewers that go to our side effects management guides that list the various forms of treatment, and then the side effects that you may experience and how those could be possibly mitigated. We have a wonderful new section of our website that we've recently updated, and it's on melanoma clinical trials. We also have a melanoma clinical trial matching service that is available to the public. So if you have an interest in participating in a clinical trial, you can go there and learn more about clinical trials and how you can apply to be a part of one. We have a service that's called Ask a Medical Expert. Melissa Wilson is a PA who works out of Pittsburgh, and we have a form that you can complete and ask questions about your care. She's not there to diagnose nor to change your plan of care, but rather to help you to understand the treatment that's being suggested by your team, or to better understand the results from your testing. As a result of the questions that have come in to her over the many years, she started a webinar series called From the Clinic to the Living Room. And there she takes those same questions, and she has done webinars complete with graphics and that kind of thing to help the public in general to understand their treatment journey. We have these melanoma symposiums. We have 10 a year. They're co-hosted by cancer organizations across the United States. What we do at the end of our symposiums, as we will do with today's symposium, is we take each presentation, we will edit it, and then we will put the individual presentations back on our website. We keep all of these presentations on our website for a period of 5 years, so that individuals can come back again and again to our website and watch the various panelist presentations. In the meantime, if you would like to see today's symposium again, if you'd like to pass it on to family or friends, you can go to Aim at Melanoma's YouTube page and go to the live tab there, and then our symposium will be live and available to the public until we then take and memorialize the individual presentations on the webpage. We also have a podcast. Noah, in fact, is a recent guest on our podcast talking about communication. She did a wonderful job, and that podcast will be aired in March of 2025. But our podcast is about not the clinical aspects of a cancer diagnosis, but rather it's about the psychosocial needs that people find that they have after they've been diagnosed with cancer. So it's about the anxiety that they may feel about recurrence, or fears that they have about spending time in the sun. Maybe it's about building a support network around themselves. So our podcast is hosted by Ray Liu, who is the Director of Cancer Survivorship for Kaiser Permanente. And I encourage you to listen to those. Those come out every month. And the last thing I'd like to tell you about is a Peer Connect program that we have. That's a one-on-one mentorship program. We have 62 individuals who have trained to be mentors. They have walked the breadth of their treatment journey, and their desire is to be a source of encouragement and inspiration for people who are newly diagnosed. And, though they may have, and I hope that everyone who finds themselves diagnosed with melanoma has a large supportive network around them, but you may find that you don't feel that you have someone in that circle of trust who understands what you're experiencing and feeling. And so this is a way to add someone to that circle. So what I'd like to do then is offer to you to help you navigate our website, to find information from there that you could use to connect you with a mentor if that is the right direction for you. And so here is my contact information if you'd like to get in touch with me. And then lastly, before I turn it back to Chris, I would like to ask at the end of today's presentation, our symposium today, you're going to get a link to a survey. And I ask you to take a moment to fill that out. We want to make our symposiums better and better. We want to make sure that we are presenting information that is relevant and important to those who are viewing. So if you would please take a moment to fill out that survey. Okay, and so with that, I'll stop sharing and I will pass the baton to Chris. And we have lots and lots of questions. It's not too late to submit a question. And so Chris, it's all yours.
All right, we have lots of really great questions today. Exciting to see what's going on in the chat here. First question, with TIL therapy, during that longer than we like period, while the cells are in the lab, can patients be on different therapies?
And that's commonly referred to as bridging therapy. And so, yes, that is certainly an option. And outside of a clinical trial, patients can get whatever is clinically appropriate. Radiation, other palliative treatments would certainly be appropriate.
Thanks, Dr. Curdy. Another TIL question. Is TIL therapy effective in all types of melanoma? As we know, cutaneous melanoma is just one of the many types. Is this working in ocular melanomas, mucosal melanomas?
Yeah, so and another excellent question. The immunology of melanomas that originate in non-sun exposed areas is certainly different, and that may relate to their mutational profile or other differences in the microenvironment, the area around the melanoma cells. And so although adoptive cellular therapy has been looked at in non-cutaneous melanomas, it's still experimental. There's some ideas about how to make it more effective. It's not, how should I say, there's some traction, but the results are not as impressive compared to cutaneous melanoma. And so that's one of the many unsolved questions in melanoma research, but in fruitful area for progress.
Thanks, Dr. Curdy. Is there a genetic component to melanoma?
Who's that directed to, Chris?
I'm just throwing it out there. Who wants to
Okay.
take that one?
Sure, I can share some thoughts. So short answer is yes, there is a very small percentage of melanoma that is of hereditary genetic cause, but the majority of melanoma is sporadic without an inherited cause. And one thing to maybe say is, is cancer genetic in the sense, well, there are gene mutations that arrive in cancer, but I think what the person is probably asking is, did this come from my parents? Is this an inherited cause? Are our children at risk of this? And fortunately, in melanoma, that's fairly uncommon.
Next question for you, Dr. Taylor. You presented on the Moderna study. Vaccines, we all know them. We've been exposed to them for a long time. Do these vaccines come with side effects?
Great question. So in the clinical trial with the Moderna vaccine in combination with pembrolizumab, the majority of the side effects that people experienced was just what we consider a local reaction, an injection site reaction, meaning where they got the shot in the arm, they would have some pain or some redness, sometimes some fevers and chills. But for the most part, it didn't really seem to dramatically change the overall side effect picture.
Thanks. This is a question I think we've been lobbing around for a while. I know I've had this discussion with Dr. Curdy in the past. Patients with stage 4 melanoma that have been treated with immunotherapy, do we see a point in the future where preventative vaccines play a role in keeping them from recurring?
Go ahead, Dr. Curdy.
Yeah, so and Dr. Taylor can add his comments as well. Prevention is a great concept, but obviously in stage 4 patients, the hope for any systemic therapy is eradication of the melanoma. And of course, the means we have for knowing whether it's gone have some limitations. I mean, scans are good and important and are used every day. But is that the same as a molecular remission? And so that's maybe it is one and the same, but maybe not. And one of the challenges is that melanoma is notorious for continuing to mutate or change over time. And so although all of the immunologically responsive melanoma might be gotten rid of by treatment, but the few rogue cells that remain, perhaps they don't have any half-decent melanoma targets, or they're too similar to normal cells to be eliminated. So I think it's an excellent question, but one that's going to take an awful lot more science work to understand and to develop good treatments.
I agree completely and have nothing to add to that.
We got a clarifying question here, and this relates to the Moderna study and vaccine therapy. Does a patient have to wait for a recurrence of their disease to be eligible for vaccine therapy?
So, good question. Unfortunately, the vaccine is currently only available through the ongoing clinical trial. Since it hasn't yet been approved by the FDA, this isn't something that we can prescribe and treat our patients with outside of the clinical trial just yet. So we don't know exactly what that'll look like. We hope that the FDA will approve it soon and we'll have greater flexibility to use it when we think it's appropriate. But as of right now, it's only offered through the clinical trial.
There's a question here, and I'll try and get to, I think, what they're getting to. If you have a response to Ipi/Nivo, and then at some point have progression of disease and are offered oral therapy, are you more or less likely to have a response again?
Do you want me to take a shot at this first, or?
Yeah, go for it.
Make sure I'm understanding. So if they've been treated with immunotherapy up front, stage 4 metastatic melanoma, and have responded, but then the cancer's progressed, and then there are oral therapies like the BRAF MEK inhibitors. Yeah, there's certainly a chance they could respond to that treatment. So it may help to shrink the tumors and get control of the cancer at that point.
And I'll put a little spin on that. If a person were to get Ipi/Nivo up front, have progression of disease, and then be offered a second line therapy, maybe combination relatlimab, would you expect the same response?
Yeah, so there are some data using other checkpoint combinations, and that's really expanding the question quite broadly, but that's been the topic of research since I'll say 2015-ish or thereabouts, looking for the best salvage regimen after checkpoint progression, especially in patients who don't have a BRAF mutation. So the short answer is, well, maybe TIL therapy for those patients who might be eligible for that. Other checkpoints after Ipi/Nivo progression have some activity, but my own bias is to say that that's a patient around which there should be a discussion of clinical trials. And harkening back to my comment that I'm the IL-2 guy, but I'll just say cytokine-based or different types of immunotherapy other than checkpoints would be part of that consideration.
Perfect. Thank you. We'll throw a softball out there. Where or how do I find out where TIL therapy is available? Dr. Taylor?
So you can ask your oncologist. Hopefully the oncologist would know of centers that are offering the treatment. As Dr. Curtis pointed out, we offer TIL therapy in clinical trials here. So it's hopefully just a phone call away to figure out where that treatment might be available.
I'll expand on that perhaps just slightly to say at the moment there are, it's my understanding, roughly 36 official TIL centers, although there's a goal to make it more broadly available over the next 6 months or so. It is certainly not widely available, and that's understandable given the technological complexities. But there'll be more centers to come, but it is honestly not widely available just at this moment.
Thanks. Another question, is there any reason I would not want to ask for neoadjuvant immunotherapy instead of just adjuvant immunotherapy? Dr. Taylor.
That's a great question. So, we're kind of stuck in a strange gray zone right now where the clinical trials have been resulted, they've been published. If we look at the NCCN guidelines, which is kind of the gold standard for how we view standard recommendations, neoadjuvant immunotherapy is recommended for patients who are eligible for surgical removal of their stage 3 melanoma tumors. But yet on the other side, if we look at what has the FDA approved for those drugs, it has not yet entered the FDA approval for drugs such as ipilimumab, nivolumab, pembrolizumab in that situation. So I'm of the opinion, yes, it is the new standard, and yes, we should be talking to our patients about this, and patients should ask their doctors about, if they're a candidate for neoadjuvant immunotherapy. So I think it's going to evolve over time, but I would say that yes, the standard is here now.
Great. Is the FDA's delay on this maybe based just on more safety data coming in?
I'm not sure. I suspect that's a complicated issue with the pharma that has to petition the FDA to change their package insert, their authorization. But in the situations where I've prescribed this for my patients in the neoadjuvant setting, we haven't received any pushback. So at least my experience so far has been that there haven't been barriers to using those therapies.
Thanks, Dr. Taylor. We'll get into some of the fun questions that we all want to know. How much do we think it will cost for Moderna to make these vaccines for a single patient?
I have no idea what their cost structure is for making the vaccine. So I don't know what that's going to cost yet.
Okay. I'll put this out to both Dr. Taylor and Dr. Curdy. Can you please describe the difference of survival rate versus a progression-free survival?
So another example of we have too much jargon. And so common sense survival is, well, how long you live, how many days on the planet. And progression-free survival is a measure of how long it takes before the melanoma starts growing again or the cancer starts growing again. And so depending on different patient subsets, if you're starting out with patients with stage 4 or some other stage, and then it comes back later, there's some nuances around that. But there's also, and so I'll just call out, there's wonderful 10-year data from Ipi-Nivo that have just recently been presented at meetings and published online. And so the very good news from that data is that at 10 years, there are survivors, and that's now commonly accepted. But when I started my career, there was no knowledge of that, and
Mhm.
no instance of that occurring. So there's been wonderful progress, but yet still about half of patients do not survive. But having said that, some survivors they succumb to other medical circumstances. So there's all-cause survival, which is different from cancer-specific survival. So melanoma patients clearly living longer, but more work to do.
Thank you, Dr. Kurdi. Dr. Taylor, is there a good medical test to determine the rate of growth of a melanoma tumor? Question of the hour.
Unfortunately, there is not. That's more of a laboratory test. We have certain surrogates that the pathologist will use based on certain stains they can expose the tissue to when they look at it under the microscope to see what percentage of the cells are proliferating. But I think what they're really asking that question is, how do I know if my cancer is really aggressive, or how fast is it going to grow and spread? And those may not line up with what we see necessarily under a microscope based on the percentage of cells that are in the active process of dividing. So unfortunately, no, there isn't a good test to predict the rate of growth.
Thanks, Dr. Taylor. Dr. Kurdi, we have a question. Can you address the limitations of using TIL on patients with unstable brain mets, and specifically why the FDA restricts use on patients with unstable brain mets?
Yeah, so there are a couple of different aspects to that. Giving TIL therapy also requires interleukin-2, and interleukin-2 is notorious for causing swelling in the body. In the brain, when there's swelling already from uncontrolled tumor, that could cause a life-threatening circumstance that perhaps would not be addressed or could be addressed with medication. Another aspect to the swelling of TIL therapy, of course, the hope is that the T cells go into the tumors, and that's true anywhere in the body. But if you already have something that is causing swelling in the brain, and there's even more, it's not just the IL-2, it may be the cells themselves that contribute. Beyond that, and getting back to my comment earlier about patient eligibility, and patients who are fairly sturdy, basically doing normal activities or only very minor restriction of those activities. Unfortunately, individuals who have brain involvement usually just are not as sturdy. And I hinted at this very briefly, but even in sturdy individuals, the risk of death is between 3 and 5% with TIL. And for patients who are not so sturdy, that risk goes up substantially. And so I appreciate the argument that if you have bad melanoma, there's a 100% chance that the melanoma will catch up with you. But I think there's a valid argument that we shouldn't actively go down a path of such high risk that our treatment will likely cause your death.
Thanks, Dr. Kurdi. Going to wrap up our Q&A here with a question for Noah. First off, thank you for the examples of ways to think about how my point of view has changed almost everything during my cancer treatment. What do I say to a family member that tells me that I'm lucky I'm cured, but I still feel cautious and anxious at times?
Yeah, thank you for that important question. I think so many people find themselves in a similar position. And I think it reflects that kind of holding both, right? Like, probably there are times where you can also tap into that reality that you are cured, or things that are going well, and also you're still feeling those many ways that life have changed. And I wonder if even offering your loved one a little bit of that framework, that both things are happening for you, and that's actually a really normal thing that everyone with cancer experiences, could just be a way of letting your person who is close to you into that full reality that you're feeling, that both things are happening. To throw another metaphor in there, I often think about like a seesaw, maybe with some joy or sadness on one end or the other. And if we're staying only in the sad feelings, right, then we don't have that movement over to the joy. And really, we're trying to have a little bit of both, right? That movement is what helps us not get stuck in any one place. Staying only in the positive also can be a little bit dangerous too, right? Because it's not acknowledging that hard part. And I think often our support people kind of want to talk us up and be saying, hey, look, things are going well, and kind of letting them know, hey, actually, both of these are important and both of these are part of my healing right now, and kind of inviting them into that process.
Thank you, Noah. Anne, passing it back to you.
Well, I just, let's end by saying once again, thank you to our friends at Providence Cancer Institute, and thank you to everyone who joined us today. We hope you have a great rest of the day. Please contact AIM if we can provide you with any resources or information. And with that, we will say goodbye.
Thanks, everyone.